Recording in progress.
Hello everyone. On behalf of Mission Gastro Hospital, we are inviting you to this new academic initiative of multidisciplinary discussion of various GI disorders. So today in this discussion, we'll have discussion on GERD, and the discussion will be done with the various faculties that we have from various specialties, the best faculties in the country and the state. So we have Dr. Naveen Patel, who is the senior most ENT surgeon in the city and very renowned name in ENT circles. Dr. Gopal Rawal, who is a senior pulmonologist in the city, practicing at his own center. Dr. Amit Shah, who is a senior gastroenterologist in the city, practicing at KD Hospital and Vivan Surgical Center, and Dr. Dhaval Gupta and Dr. Pratim Bhatt, who are gastroenterologists at Mission Gastro Hospital. So with this, I think our first talk is Dr. Pratim Bhatt, where he'll give us a 20-minute talk introducing about GERD and the management, and then we'll have a panel discussion about multidisciplinary management. So over to you, Dr. Pratim.
Good evening.
Good evening.
So today's topic is the gastroesophageal reflux disease, very common in all kind of practice from gastroenterologist to gynecologist. Everybody have a same problem, heartburn. So there is a common topic, and we are going through slides very fast, and then we have a long discussion. So what is the definition of GERD? So GERD is a condition which develops when the reflux of the stomach content causes troublesome symptoms and the complication. This is the simplest definition given. But the second is the objective definition. Objective definition is the when there is a presence of characteristic mucosal injury seen on endoscopy and or abnormal esophageal acid exposure measured on pH impedance pH manometer pH metry, then you can label somebody has a gastroesophageal reflux disease. So what is the pathophysiology? So first we have to see for the defense mechanism that prevent the reflux. So usually reflux at a various defense mechanism from cricopharynx to the stomach. So in the if intact salivary production, intact reflux induced swallow mechanism in the cricopharynx, then in the esophageal body, intact primary and secondary esophageal peristalsis and intact esophageal tight junctions. That at the G junction there is infrequent transient ileus relaxation, intact lower esophageal sphincter tone, and there is a overlap between lower esophageal tone and lower esophageal sphincter and diaphragmatic crura to that overlap prevent the entry of reflux into reflux of acid into the esophagus and normal gastric emptying. When there is abnormality in any of the above reflex defense mechanism, that can lead to GERD. When there is a decreased salivary production, like in xerostomia or impaired reflex-induced swallowing, very common in elderly patient, Parkinson patient, such patients are always at risk of GERD. When there is a esophageal peristaltic disorder like hypomotility disorder, a fragmented peristalsis, ineffective esophageal motility, or absent contactility, such patients have a poor acid clearance, and that can lead to esophageal injury, erosive esophagitis. G junction is a very important defense mechanism. When there is a decrease in lower esophageal sphincter tone and hiatus hernia is there, then patient have a highest chance of reflux. And if patient have a delayed gastric emptying or increased acid secretion, both the conditions can lead to increase in GERD. So how most of the GERD pathology is revolve around G junction, because G junction is the main defense mechanism against the reflux of acid into the esophagus. So normally there is a close overlap between the lower esophageal sphincter and crural diaphragm. So there is a no hiatus hernia and the normal LES pressure when there is no swallowing. The LES relax only and only when the person have eating or liquid swallowing. So there is no acid reflux, and only transiently there is a LES relaxation only after eating for gas venting. So now normal condition, if any acid is escape into the esophagus, there is an intact esophageal peristalsis that will clear the acid rapidly. So there is no esophageal injury in a normal person. But if G junction is impaired, then there is a decrease in LES tone and LES pressure. So when there is an increase in intra-abdominal pressure, then there is a hiatal dilatation and distensibility with intermittent sliding hiatal hernia that can lead to a reflux of acid into esophagus, and patient can have a heartburn and regurgitation. And such patient have a normal endoscopy or can have a LA grade A or grade B esophagitis. But if a patient can have permanent damage to the G junction, then there is a laxity of lower esophageal sphincter. There is a loss of overlap between LES and crux diaphragm and development of hiatus hernia, and that can lead to a acid pocket theory. It means then when there is the intragastric part of the stomach, infradiaphragmatic part of the stomach will extend into the esophagus, and that pouch will contain acid all the time, and that can lead to a persistent esophageal injury and can so that patient develop high grade erosive esophagitis in the form of LA grade C or grade D esophagitis. Patient can have Barrett esophagus also. So what are the symptoms of GERD? The classic symptoms are the heartburn and the regurgitation. Chest pain and dysphagia are also attributed to the GERD in most of the cases. The less common symptoms are the odynophagia, water brush, subziphered pain, and nausea. Extraesophageal symptoms are also common in other specialties like chronic cough, laryngitis, asthma not responding to or poorly controlled with the available medication, dental erosions. Then other proposed are the pharyngitis, sinusitis, recurrent otitis media, and idiopathic pulmonary fibrosis. But majority predominant symptoms always are 80% are heartburn. So heartburn should be there when a patient have a clinical diagnosis of GERD. As per Montreal classification, we can divide GERD symptoms into the two groups, esophageal and extraesophageal. And esophageal syndromes are divided on the symptomatic basis or with symptomatic plus mucosal involvement, mucosal disease. So when patient have a symptomatic heartburn and regurgitation with normal endoscopic finding, then patient labeled as a non-erosive reflux disease. If patient have evidence of esophagitis, stricture, Barrett esophagus, or adenocarcinoma, such these are the classical patient of GERD. And for extraesophageal syndrome, the established association are the chronic cough, laryngitis, asthma, and dental erosions. And proposed associations are otitis media, pharyngitis, sinusitis, and idiopathic pulmonary fibrosis. Diet and GERD, very common hot topic among patients and as well as among consultants. Patient always ask about what to eat and what not to eat in the GERD. So most of the food that provoke GERD act on the lower esophageal sphincter and they relax the lower esophageal sphincter when they are consumed in excess amount. So coffee, actually caffeine beverages reduces the lower esophageal sphincter and can produce acid reflux. Citrus fruits, especially pineapple and grapefruits, that have a high acid content. So the patient with presence of esophagitis have a higher burning, esophageal burning and regurgitation. Chest pain is also provoked with the citrus food. Tomato and processed tomato sauce and pizza and pasta sauce all are highly acidic. So that should be avoided if someone has a GERD. Carbonated beverages cause increased distension of stomach and the fundus that can lead to a relaxation of lower esophageal sphincter. So it can produce GERD. Chocolate contain methyl xanthine and it's also a relaxant of lower esophageal sphincter. Peppermint, garlic, and onion also relaxes the sphincter and cause the reflux. Fatty, spicy food, and fried food all are known to cause lower esophageal sphincter relaxation, causing delayed gastric emptying, and they can provoke the reflux. So diagnosis of GERD. This is I have taken this slide from American College of Gastroenterology. That is, they suggest that diagnosis of GERD always made on clinical ground. The patient with classical symptoms of heartburn and regurgitation without any alarm symptoms and with empirical trial of PPI. If patient have a symptom response, then patient likely to have GERD. So this is the classical uh, uh, guideline for the diagnosis of GERD. So for GERD diagnosis, no investigation is required. Only symptom troublesome heartburn and regurgitation are the dominant symptoms. But if patient have a chest pain, then one should exclude the heart disease, and then patient require additional investigation in the form of endoscopy and pH metry. Barium swallow is not recommended, and endoscopy is recommended when patient having alarming symptoms like dysphagia, weight loss, GI bleeding, or the risk factor for Barrett esophagus, especially female, elderly female, Caucasian ethnicity, obesity, and smoking are the risk factor for Barrett esophagus. Uh, when diagnosis of GERD is suspected but not clear in such kind of patients, pH monitoring is always recommended to confirm the diagnosis. But when patient already have a have a LA grade C or D esophagitis or long-standing Barrett esophagus, in such cases, diagnosis of GERD is confirmed and no pH metry is not recommended. So this is same clinical diagnosis is based on the classical symptoms of heartburn and regurgitation, and with patient have a response to PPI, it should be considered the diagnosis of GERD. Barium swallow is not recommended. However, many times patient come with a barium swallow. Majority time barium swallows are normal. That is only useful when patient have a large hiatus hernia or patient having stricture. Otherwise, most of the time patient with GERD, patient have a normal barium swallow. Endoscopy, as I already told, it is recommended when patient having alarming symptoms like dysphagia, weight loss, if patient do not respond to PPI therapy or patient have a persistent symptoms on PPI, then one should go for endoscopy. And endoscopy also done before doing any invasive procedures, endoscopic or surgical procedures for hiatus hernia. So to look for hiatus hernia, presence of any evidence of esophagitis, presence of Barrett esophagus, and also look for any peptic stricture is there or not. One should go do an endoscopy. So Los Angeles grading is developed to define esophagitis. But now studies have showed that LA grade C and LA grade D esophagitis are related with the pathologic acid exposure, that is GERD. But LA grade A and LA grade B esophagitis can occur in patient without GERD. So grade C and grade D esophagitis are telltale sign of GERD, but grade A and grade B are not. Long segment Barrett esophagus is also a diagnostic of GERD. Esophageal pH metry, it is very newer test, but it is very commonly prescribed when patient have a patient was subjected to for any anti-reflux surgery or anti-reflux endoscopy. One should have a confirmed diagnosis of GERD and GERD. So objective diagnosis of GERD is made when the acid exposure time is more than 6% and higher domestic score, then patient can have a patient is diagnosed as a GERD. Esophageal pH metry is also done when a patient is not responding to PPI therapy, or when the diagnosis of GERD is not clear, or patient will have an extra esophageal manifestation, and this manifestation are suspected is due to a GERD. In such cases, esophageal pH metry is recommended before embarking any definitive therapy. Role of manometry. Esophageal manometry has a role in to define any anatomical and any neuromuscular abnormality in the esophagus and the G junction. So one manometry is done to look for hiatus hernia. You can see in the left of the slide. First is the normal swallow, where lower esophageal sphincter and crux diaphragm is closely overlapped, while in the second slide, there is a separation of LES and the diaphragm. This is the feature of hiatus hernia. In manometry, there are three things to be seen, and it is more important for the surgeon when patient is planned for the hiatus hernia surgery. For G junction, if whether G junction is normal, the LES pressure is normal or not, whether it is hypotensive, or there is definite evidence of hiatus hernia. All three things can be seen on the manometry. For esophageal contraction, peristalsis pattern is also we have to look for very carefully. If there is ineffective esophageal peristalsis or fragmented peristalsis, uh, when it is more than 50%, then it is pathological. When there is absent esophageal peristalsis, it is also one of the contraindications or for surgery, or one of the predictor of post fundoplication dysphagia. If patient have a weak or ineffective peristalsis, one should do a provocative test like rapid water multiple rapid swallow test, where patient is given multiple rapid swallow very frequently. If patient have a peristalsis reserve, adequate peristalsis reserve, patient have a augmentation of esophageal peristalsis, DCI is augmented, and if it is augmented, then patient can undergo surgery. But if there is no augmentation of the esophageal peristalsis, then patient is suspected to have low contractile reserve, and such patient have a risk of dysphagia if a patient have a tight wrap during fundoplication. For diagnostic algorithm for especially extraesophageal manifestation, one should look patient very clinically. If patient have only symptoms of GRD or definite symptoms of any other specialty, if patient have a chronic cough or any other or laryngitis, then patient should be referred to their subspecialty specifically. And if patient have a typical GERD with extraesophageal symptoms, then patient should give an empirical trial of PPI twice a daily for 12 weeks. If patient have a symptom response, then patient should be considered as a GERD with extraesophageal manifestation. But if patient has no improvement, patient should undergo a pH monitoring after stopping PPIs. Similarly, if patient have a predominant extraesophageal symptoms or only extraesophageal symptoms and no GERD, then such patient should undergo pH monitoring of PPI. And if it is abnormal, then patient should be considered as a GERD. Otherwise, patient should be treated as a specialty symptoms. Treatment is basically defined in the four main pillars. Like one is lifestyle management, second is medical management, third is endoscopic, and fourth is surgical management. So lifestyle management very common across the all cultures and communities all over the world. There are more or less same recommendation: avoid fatty meals, avoid carbonated beverages, avoid citrus food, eat small frequent meals, weight loss therapy, avoid alcoholic beverages, stop smoking, avoid excessive exercise, sleep with head and elevation, and sleep in left lateral position. But if you look at the same slide, the level of evidence are different. So, but all are most of the things are very harmless. So we can suggest patient to follow such lifestyle modification. Medical management. So, American College of Gastroenterology suggests proton pump inhibitor therapy over histamine to receptor antagonist for healing of erosive esophagitis. Similarly, they also recommend the PPIs over H2RA for maintenance of healing in erosive esophagitis. PPI should be administered 30 to 60 minutes before a major meals, not at the bedtime. And those patients who have a complete symptom resolution and they do not have any evidence of erosive esophagitis or Barrett esophagus, all attempts should be made to discontinue proton pump inhibitors. And patient can take PPIs as and when if patient has symptoms. Otherwise, PPI should be discontinued after the trial of 8 to 12 weeks. For a patient with GERD who require maintenance therapy of PPI, PPI should be maintained at the lowest possible dose so that they'll maintaining the healing of esophagitis. We recommend not to add any other medical therapy on PPIs if patients do not respond to PPI. Rather than such patients should be investigated for the non-response of PPIs. We recommend the maintenance PPI therapy indefinitely for patient with LA grade C or LA grade D esophagitis. Or if patient do not want to do not want a lifelong PPI therapy, then patient should give an option of anti-reflux surgery. Baclofen should not be used in absence, should not be added if there is no definite evidence of GERD. Prokinetics are also not advised unless patient having definite evidence of gastroparesis. And sucralfate are also not recommended for GERD therapy except in pregnancy. And on-demand PPIs are always given if patient is otherwise asymptomatic. Why some of the patients do not respond to PPI, while other majority of patients have a response. So there are few causes of non-responsiveness to PPI. So first and foremost is the continued abnormal acid exposure even after taking PPIs. That is very common when patient is taking once a day PPI or patient taking short-acting PPI like pantoprazole or omeprazole. Patients should be switched to a longer-acting newer generation PPI like lansoprazole, esomeprazole, or rabeprazole. With this PPIs have a longer half-life up to 18 to 20 hours. Second possibility is the patient have a reflux hypersensitivity. It is a condition where there is a complete acid suppression with PPI, but when patient have a physiological exposure of acid or non-acid content, then patient develop symptoms. So that is a reflux hypersensitivity. When other another possibilities are patient have a other esophageal disorder that is mimicking the GERD like eosinophilic esophagitis or echinacea cardia. Other possibility are the non-esophageal disorders that can mimicking GERD like gastroparesis, rumination, or heart disease. And the last possibilities are the functional patient have a no evidence of GERD or any other abnormality, and such patient do not respond to PPI. Surgery. I will brief my restrict this slide for only indication and and role of manometry and pH metry in the surgery. Surgical part discussed in the panel. So indication for anti-reflux surgery are the troublesome and persistent GERD symptoms, and when patient do not want to take PPI, and when patient preference to go for surgery and not to take medicine, GERD patient have a GERD complication, or patient having large hiatus hernia, such patients do not respond to PPI very well, or patient have very high volume reflux. Role of pH metry and manometry. Before patient underwent any surgery or endoscopic therapy. High resolution manometry is recommended, especially to rule out achalasia cardia and absent contractility, because these two are the contraindication for anti-reflux surgery. If patient have a ineffective esophageal motility, then patient should undergo other provocative tests like multiple rapid swallow or free water challenge test. Before performing any surgery or anti-reflux endoscopy for GERD, one must ensure that the diagnosis of GERD is confirmed. So, objective diagnosis of GERD is always should be made before doing anti-reflux surgery. And manometry is done to rule out achalasia or absent contractility. Endoscopic therapy. This is I also brief to only 2 to 3 slides. There are newer therapies, and it is also not for large hiatus hernia. It is only for a very selected group of patients. So there are I will just list their names: anti-reflux mucosectomy, anti-reflux mucosal ablation, GERD-X device. There is full thickness plication technique, and the SARTA, that is radio frequency ablation of the lower G junction, lower esophagus. Indication is the same: patient with troublesome regurgitation or heartburn and who do not want to undergo surgery, or especially there are very selected group of patients, those who do not have a severe esophagitis, or patient with small hiatus hernia up to less than 2 centimeter. More than 2 centimeter, surgery should be done. Endoscopic therapy is not effective. Contraindication are the LA grade C or grade D esophagitis, esophageal stricture, and long-standing Barrett esophagus. So this is the ARMA procedure. So on the right side, you can see there is a horseshoe ablation of the gastric cardia, and this ablation will lead to a stricture, scarring formation, and that can lead to a flap valve mechanism that can prevent the acid reflux. And on the left hand slide, you can see when there is a horizontal dilatation of the hiatus. In such cases, endoscopic therapies are effective, especially ARMA. But when there is a component of sliding hernia, in that case, surgery is recommended. So you can see there is a cutoff at 2 centimeter. When there is more than 2 centimeter of sliding hernia component, where patient always subjected to surgical treatment, endoscopic therapy is not effective. And this is a GERD-X device. This is a full thickness plication device where you can do a plication of the gastric cardia, and that can lead to augmentation of the lower esophageal sphincter pressure. And that is very, the end result is very similar to a fundoplication. And this GERD-X device can be used up to hiatus hernia of 3 centimeter. So thank you. Now I stop sharing my slide and you can start a discussion.
So thank you, thank you, Pratin Bhai, for very crisp presentation and covering almost all the aspect, touching almost everything. Now we'll move to the panel discussion. I'll share my slides and questions so that everybody can see what are the questions asked. Uh, so we'll start with Dr. Dhaval Gupta regarding the gastrointestinal aspect and the common questions we have in our mind. So, Dr. Dhaval, what should be the treatment protocol for refractory GERD?
Uh, yes, thank you, Chirag bhai. As Dr. Pratin already described the mechanism of the refractory GERD, first of all, we should try to find out what are the potential mechanism for the refractoriness of the symptoms. First of all, we should assure the compliance of the PPI both in the form of dose and timing. Patient should be reinforced to take it before the 30 to 45 minute or 1 hour, and also dose should be checked if it is patient is taking once a day or twice a day. It should be optimized to twice a day, and as per the refractory, he must be on the twice a day dosing. Then reinforcing the dietary and other lifestyle measures to stop smoking should be advised to weight more loss. Many of the patients might not be following the proper lifestyle modification. Then based on the etiology and testing like the 24-hour pH metry and impedance metry, we should try to categorize the patient based on the if the patient is persistent acid reflux patient. Then if it is so, then we should double the dose of the PPI along with changing the PPI to the CYP independent molecule. Apart from this omeprazole or pantoprazole, we can shift to the lebeprazole or the esomeprazole or even lansoprazole. And there is also a few of the studies have shown the splitting the dose of the PPI. If patient is taking once a day, then splitting the dose have shown to be beneficial.
Okay.
If the it has been found to be nocturnal acid breakthrough in the impedance metric, then we can also again we can split the PPI dose, or we can change it to the CYP independent, or also there is a small role of the H2 blocker for the occasional nocturnal acid breakthrough patient. And apart from that, if the patient is functional hypersensitivity, or there is a patients with the reflex hypersensitivity, they should be tried on the SSRI or SNRI or even trazodone.
Okay.
If there is any evidence of the volume reflux or delayed gastric emptying, then we can add the prokinetic agent. Otherwise, there is no much evidence of routine use of the prokinetic in such patients. And if the still patient has the persistent symptom or the refractoriness, we can go for the endoscopic or the surgical management of the GERD.
Right. In which patients you will give lifetime PPI advice?
Uh, Particularly the patients with LA grade C and esophagitis. In studies, it has been shown that most of such patients recur within the 6 months to 100% of the patient after the stopping the PPI. So these patients are advised as per the ACG guideline that indefinite PPI should be given. Also, the in Barrett's patient indefinite PPI is advised, and also the patients who are PPI dependent or are not responding, have the hiatus hernia but are not candidate for the surgical intervention or endoscopic intervention, they can continue the PPI for a lifelong.
So, what are the side effect concerns for the long-term PPI, sir?
There are lot of population-based studies have shown a lot of side effects, but in clinical practice, we are not finding any major side effect. Common side effects we find in the clinical practice are the abdominal pain, nausea, headache, some of the patient pharyngitis. Apart from that, the B12 and the vitamin D deficiency has been shown in long-term usage. Also, calcium, iron, and manganese deficiency. Some of the studies have shown the increased risk of the CKD because of the hypomagnesemia and AKR risk. Also, a few of the studies have shown that risk of the dementia, because it has been studied that the PPI increase the amyloid beta peptide molecule in the body, and which are the for component of the amyloid plaques in the Alzheimer's disease. So it has been, apart from that, the cardiovascular side effects and all that have been found in population-based studies, but are not much clinically significant.
I think so. I think
And also, And there is a
I would like we should restrict the discussion to the practical side effects. So please share your practical experience of the side effects.
Practically, generally, we see mainly the occasionally there's a nausea or headache and pharyngitis, and we have seen that a few of the patients of long-term usage that some of the patient had B12 deficiency and vitamin D decrease in the bone mineral density. Otherwise, we have not encountering much of the renal or other CNS side effect.
Okay. And do you think any, I think you have discussed the next question. So what are the role and options of endoscopic treatment in GERD? I think we can discuss that after the surgical discussion. So we can move to the next specialist. Sir, Dr. Naveen Patel, sir, who is a senior ENT surgeon. Sir, we have a lot of questions regarding GERD from our side also. So the first question is, what are the ways in which GERD presents to you?
Yeah, thank you, Chirag Bhai, and the Mission Gastro Hospital for inviting me. The way the GERD presents to an ENT specialist, especially the laryngologist, is this: it presents as a change of voice, or the second commonest problem which we face is a foreign body sensation in throat or a persistent cough. They do complain about their worsening of sinusitis, or they have a persistent pain in the ear, or they come to you with their teeth becoming very brittle, and they occasionally have a severe burning sensation in the throat. So these are the commonly way the patient presents to a laryngologist and the ENT surgeon.
Okay, sir, whatever referral we get are mainly for chronic cough and change in voice. So do you really see patients with recurrent otitis media?
Especially in the patients who has other causes ruled out. See, so the problem is we keep that into mind when the other common causes of the otitis media is ruled out.
Right.
Especially when a patient is obese and adult male presenting with an earache,
Okay.
And otitis media.
So what are your common indirect laryngoscopy findings on GERD?
I would correct it to the other way around. Nowadays, our indirect laryngoscopy is gone. We do more of laryngeal telescopies, and we do more of a flexible nasopharyngeal laryngoscopic examinations. We use flexible nasopharyngeal laryngoscopic examination more with a narrowband imaging and with or without stroboscopy. These are our normal investigative modality when we are suspecting laryngeal presentation of GERD.
Right.
And the findings which you see is very grossly red arytenoids and A-fold, or you see a interarytenoid region having a specially valvety appearance, or you can see polypoidal changes into the posterior glottic area, and you can see occasionally a granuloma over the arytenoid vocal process of arytenoids. You can have a very, very typically a granular appearance of A folds, and you can have a lot of puckering seen into the both pyriform foci with a gross red appearance. So these are not an indirect laryngoscopy findings. What I'm talking about is a direct laryngoscopic finding, and preferably with a flexible nasopharyngeal laryngoscope.
Those are like similar to our endoscopes, right?
You're like they're all cheap on tip and very high end endoscopes.
Right. So what is the next line of investigation when you suspect GERD in such patients?
When I suspect GERD, I usually try to treat them with PPI by myself, because they come to you with a lot of anxiety.
Right.
We give them PPI for adequately safe. My protocol is about 2 months. I give them and tell them that you come back after a month or 1.5 months. If you're not improving, then you may require a gastroenterologist opinion with endoscopy or pH metry. This is a commonly advised investigation which I prefer. By and large, I avoid doing barium swallow, and I like getting manometry done when they are refractory in management.
So right, sir. So two questions from in my mind. One, that how many of your patients of GERD do not end up to a gastroenterologist, and number two, that for us for diagnosis of GERD, the treatment trial is 2 weeks, and for you it is around 3 months, even in the guidelines, 2 to 3 months. So why is it so? Why the response is late in ENT symptoms?
You know, this is what I tell my patients also, that your stomach is acid resistant, your esophagus is little acid resistant, but your larynx, throat, and pharynx is not acid resistant at all. They have a different epithelium. They have a different mucosa. So once you have an acid injury, it takes long time to heal.
Right.
So it's totally a different mucosa. So
Right.
if you have an acid injury, don't think that it's going to improve in a matter of a week or 2 weeks. It is going to take a long time.
Absolutely. So this is very important point to keep in mind, friends, that when the reflux symptoms are extraesophageal, it may take very long time to resolve. Sir, any patients of GERD require ENT surgeries like for what vocal cord nodules or GERD along with medical therapy?
In fact, it's the other way around. So when I am doing the surgery for my vocal cord polyps, or when I'm treating vocal cord ring edema, it's not actually nodule, Chirag bhai. It's
Yes,
actually a ring edema. It's a diffuse edema of the vocal cords.
okay.
And they are known as ring edema. And when you see this kind of patients with a profuse swollen vocal cords with hoarseness of voice and a polyps, I in fact tell them that, look, even if I do a surgery, your surgery is bound to fail. You may not get desired result. So in fact, what created anda pehle aaya ya murgi pehle aayi?
Right, sir.
So what came first? The GERD came first, and then the polyp came in.
Right.
So if I don't treat the cause, then my surgery is going to fail.
Right.
So we counsel them that, look, you don't need only one surgery. You may require a long-term medical therapy. If it doesn't work out, you need a gastroenterologist's help also. So we have seen a good, even surgical therapy of GERD resolves a lot of problems in the larynx. So all my patients who I am talking about a surgery where I'm suspecting GERD as a cause, I counsel them aggressively.
Right. Right.
But nodules are not a common presentation of GERD. Nodules is a abnormal abuse of the vocal cords.
Okay. So thank you, sir. Thank you for your inputs. Please be on the panel. We have a quiz after the session, and we'll need your inputs during the discussion. Please be interactive during the discussion. So
Sure.
we have a national faculty, Dr. Rajesh Sainani, who is a motility specialist known across the country. He's teacher to all of us for manometry and pH metry. So it's our pleasure to have him here, and we have some questions for him also. So, Dr. Rajesh, how do you label as somebody as refractory GERD?
So usually we call somebody refractory when they have not responded to twice daily PPI for 8 weeks. That's whom I would call refractory.
So, what is your investigation algorithm when you label somebody as refractory GERD?
So if he's a patient who has not had an endoscopy, I would get his endoscopy done first. Preferably, I would like to get his endoscopy done off the PPI for at least 2 weeks. And if the endoscopy does not make us, gives us any more information, if it's a non-erosive reflux disease, then I would like to do his esophageal manometry with a 24-hour pH impedance study.
Do you do manometry and pH with impedance in all your patients?
So in patients
Like,
with refractory GERD with a normal endoscopy and
yes.
ongoing symptoms, the answer would be yes.
Okay.
The problem is that pH impedance is little more costlier than just pH. So ideally, I would like to do pH impedance because it tells us both acid and non-acid reflux, while only pH will tell us only acid reflux. So
So,
there's a costing issue in that. But yes, a manometry and a pH study for all refractory patients would be the ideal setup.
so ideally, when should manometry and pH metry should be done? Like, I am asking for patients who are already on PPI. So should it be done when endoscopy is normal straight away, or you give 4 or 6 weeks of PPI and then do pH and manometry?
Always, I never do it upfront. Most of our patients who get referred to us either have taken adequate therapy, but if from the history I realize that they have not taken a continuous therapy of 8 to 12 weeks, or they have not tried a switch to another PPI, as we do in refractory patients, they have not tried a twice daily schedule, or they have poor compliance, then these patients I would like to get a 8 to 12 week therapy first and truly call them refractory. Tell them that the next step is may or may not be surgery. So if you are going to be looking at anything else further, please also practice your lifestyle changes aggressively to truly call them refractory.
So, sir, when do you do a pH study with on PPI, and when do you do it off PPI?
So most of them, almost 99%, we do off PPI because it is the question that we have to answer. So if the question you have to answer, does my patient have reflux disease? Then you have to do it off PPI. But say you have a patient who is proven reflux, like we had patients of Barrett's esophagus. So they are proven reflux or C and D category, and they are on twice daily PPI and they are still getting symptoms. So you want to say, why is this patient still getting symptoms of, say, a patient with Barrett's esophagus on twice daily PPI? Or why is this patient on twice daily PPI? The Barrett's is progressing. So you did one endoscopy today after 3 years. When you do a surveillance, the length of Barrett's has increased. Then you want to say that are the PPIs really working? And that's when I want to do the study on PPI. So almost as a rule, most of our patients, we are trying to ask the question, does this patient of non-erosive reflux disease have reflux, or does this patient with extraesophageal, as Dr. Patel said, of laryngitis or change in voice, is this reflux causing the symptoms? So we like to do it off PPI.
Okay. When do you refer a GERD patient for surgery in your practice?
So anybody with an anatomical defect, so a significant hiatus hernia, and the main symptom I take is volume regurgitation. So where the volume regurgitation affects their quality of life, when they're not able to lie down, if they bend forward, liquid comes up. During the day, the liquid comes. These are the patients who really do well with reflux surgery. So the volume refluxers and those with a hiatus hernia of at least 2 to 3 centimeters. They are the ones I sent.
Okay, and a special question of a post-surgery situation. So how do you investigate these patients for reflux, like post-surgery reflux or dysphagia symptoms?
So definitely for dysphagia, I want to do a manometry first, and I usually do a barium swallow with that to say whether the dysphagia is because of a tight wrap, is there hold up at the LES, and we would do the barium in a upright position and in a supine position to eliminate gravity, to look whether good esophageal motility can empty the esophagus or not. So that's for dysphagia. But if the patient continues to have reflux, we would first do a manometry and then I would do a pH impedance. And we do notice frequently that many of the patients probably just have a reflux hypersensitivity rather than a reflux after a good anti-reflux surgery.
So what do you do with this patient?
So if they So if there is if after anti-reflux surgery, that is after laparoscopic fundoplication, if I have a normal manometry and a normal pH study, then for their reflux hypersensitivity, we would put them on SSRIs or amitriptyline to help reduce their hypersensitivity. But studies have shown that even though you tell the patient that you don't have reflux, 30% or even 40% in one study said that they just start self-taking the PPIs.
Okay, that's interesting. Thank you. Thank you, sir. Please be on the panel. We'll move to the next specialist. Dr. Gopal Rawal is a senior pulmonologist and will discuss pulmonology related issues associated with GERD. So, sir, what are the respiratory presentations of GERD? Gopal, sir.
Yeah, first of all, thanks Dr. Chirag and Mission Gastro team, and really I appreciate the discussion because GERD, what we consider it's a team multimodality approach, and you have to keep your eyes widely open. So most of time when we got the patient, that is a intractable coughing, sometimes choking sensation also, breathlessness. Patient might have some aspiration, and particularly we are facing two main conditions, asthma and interstitial lung disease, to treat them, and they have a disproportionate coughing there. So at that time we have to suspect that these patients, or what we call is a difficult asthma, in that we consider that we have to rule out the GERD.
Okay, so what is the prevalence of GERD related problems in your respiratory medicine? So, like, how many percent of your asthma or idiopathic pulmonary fibrosis or interstitial disease would have reflux as a cause?
Yeah, obviously that what we have seen initially, that it was idiopathic pulmonary fibrosis, but nowadays a few studies suggested that 60 to 70% of patients of interstitial lung disease, they might have a GERD or silent GERD, that we have to find it out and we have to treat in that way. And even asthma, that's a 20 to 30% patients of asthma patients, and particularly moderate to severe asthma, they might have a GERD, the underlying GERD, so that we have to suspect. And obviously the other disease, particularly as a sleep specialist, I have seen sometimes the patient having the choking sensation, and those patients who are not obese and having the choking sensation and might have some irritation of throats and all that. My seniors like Dr. Naveen Patel might comes to him also, that they come to us for the evaluation of the sleep apnea. In that I have to suspect that this patient might have a GERD, and if simply I diagnose GERD and treat, so we can avoid the unnecessary sleep study also.
Okay, so we have seen the algorithm for GI and ENT. Would like to know that how do you work up your GERD patients? Is it a clinical trial? How long is the clinical trial required?
Obviously, that as Dr. Naveen Patel says, that we used to give our patient PPI for at least 4 to 6 weeks and just see the symptoms. And when particularly when we have a disproportionate symptoms of coughing, breathlessness, throat irritation, in that time we just gave them to give PPI for 4 to 6 weeks. And obviously we explain that if your symptoms are not resolved, then you may need a gastroenterologist opinion also.
Okay, so again, I think the next question is, do you really consider pH metry in any of your patients, or it's mainly PPI? Because many of your asthma patients are chronic patients. So if you suspect GERD in those patients, and if they have responded to PPI, then what is your plan? Do they take lifelong PPI, or you send them for surgery also sometimes?
Sometimes I think we have a few patients, asthma patients, that after optimizing all the treatment, they are not getting better. So that few of them we diagnosed to have, we referred to the gastroenterologist and diagnosed to have this GERD problem. And we open them at any surgical or any GI gastroenterologist based treatment.
Okay, thank you, sir. We'll be moving to the final treatment of GERD, that is surgery, for many patients where the hiatus hernia is big, or there is very lax LES and the patient is refractory, or patient is dependent on lifelong PPI. Before we ask some questions to Dr. Amit Shah, I would like to tell all the participants that we have a quiz at the end of this session, and you have to log into kahoot.it, kahoot.it. Even our panelists or faculties can also participate in that quiz, and we'll be giving a GI book to them, a practical GI book for as a prize. So, Dr. Amit Shah, the next question is, what percentage of GERD patients undergo surgery?
Thank you, Mission Gastro, for inviting me. As a surgical faculty, I am speaking last on this topic. Just that shows that our pro to go for surgery is very less. I don't know the exact number, but probably they are less than 10% of the patients who we offer for surgery.
And who do you think are the right patients for surgical therapy for reflux disease?
Yeah, so usually we say that let this patient on surgery. So the patients who are on prolonged PPI, they are tired of the medicine, of course. And again, if they are responding to the medicine, they are the good candidate. Number two is the patient having anatomical problems like hiatus hernia. They will definitely benefit more than a patient with Barrett's esophagus or peptic stricture. These are the candidates we usually offer, usually benefit more with the surgery.
And what are the surgical options like total fundoplication or partial fundoplication? How do you choose among them?
Yeah, so by and large, the option total Nissan fundoplication 360-degree wrap is the ideal surgery, and that is what usually we prefer in majority of the cases. Except if there is a esophageal ineffective motility, then we will choose to go for a partial fundoplication. But recent studies says that even those patients are getting more benefit with similar benefit with total fundoplication also. But in my practice, I prefer to go for partial for those patients with ineffective motility.
Okay. I think we have discussed the preoperative workup in the previous session. So mainly esophageal manometry, pH metry, and its indication. So we can move to the next question. That is, what are the post-operative problems and complications following GERD surgery?
Yes, so it's a surgery, and I can divide those complications into two parts. The acute complications, which are the immediate post-op complications like esophageal injury, gastric injury, bleeding from the short gastric vessels. These are the technical issues, and probably the those kind of complications are very, very less than 0.1% to my knowledge. The other delayed complication we can think of are the commonest one is the dysphagia. Around 30% of the patient usually feel dysphagia post Nissen fundoplication in initial period. Maybe not significant, but some kind of dysphagia, which will be okay over 2-3 months. And the other complication is wrap migration. That again lead to acute exacerbation of the symptoms, dysphagia, and that asks alarming intervention, because otherwise it can lead to severe complications. Apart from that, gas bloating is one of the complication patient may have later in life. Recurrence of the symptoms, these are also possible over long run, and few patient may need again need to restart PPI in a long run.
Sir, which patient do you consider for long-term medical therapy and you would not like to operate?
Yes, there are few patients, of course, where the anesthesia risk is very high. Those are the patient. Second, the patients which does not categorize into a ideal surgery, means very good surgical candidate. Say, for example, the patient does not fulfill the basic criteria of pH metry, manometry, and those we usually avoid to go for surgery. I think the majority of patients are the medically unfit patients.
Okay. And do you do surgery for patients who have esophageal stricture or Sachsky's ring associated with reflux, or are
Yes.
there hurdles for you or not?
No, basically when it is not a very tight ring, tight stricture, passable peptic stricture we do perform, and we have small but encouraging results that those patients do well. Of course, that has to be not very tight stricture.
Okay, so we have 2 more minutes for free questions. We have eminent panelists. So if all of you have any questions, or Santosh, if we have any questions from the other participants, then you can give the questions to the panel.
May I ask one?
Yes.
Yeah, recently I encountered one patient who is at present not asymptomatic as far as the GERD is concerned, but patient had symptoms of GERD before 3 years. At that time, endoscopy was done, and there were changes of type C esophagitis. So patient underwent repeat endoscopy because he was visiting Ahmedabad, and again the changes of were type C esophagitis, persistent changes, but patient is asymptomatic. Patient is having legs hiatus. So how to proceed, or what to advise this patient? Patient is asymptomatic.
Pratin bhai, can you take this question?
Amit bhai, this can be very common on the GERD patient. They can have a hyposensitive esophagus, means they have a continuous ongoing esophageal injury, but they do not perceive heartburn or regurgitation as the symptoms. So this is the possibility very common in 20% of the cases.
Okay.
So this patient has to consider a GERD and has to treat it aggressively with the double dose PPI.
Okay. And so, but means I was.
And second, I want to add is such patient with esophagitis like grade C or grade D, after 2 months, one should repeat the endoscopy to look for underlying Barrett esophagus or underlying adenocarcinoma.
Okay.
We have a few questions from our participants. One is, how frequent is the coexistence of GERD and H. pylori? Pratin bhai.
I think this is a negative correlation. The H. pylori related gastritis lead to atrophic gastritis, so that can lead to reduced acid production. So there can be, if you treat the H. pylori in such case, there will paradoxically rise in acids production, and that can worsen the GERD. So for asymptomatic cases, H. pylori should not be treated as per the guideline. So H. pylori has no relation with the GERD.
So, okay. So Dhawal bhai, we are coming to next question, which is for you, that how to manage a GERD with lax gastroesophageal sphincter.
Okay. If the patient is patient is symptomatic, then And if it is already on the PPI, then we should try to optimize the PPI dose and look for the if whether he is following all the lifestyle and dietary modification and all. If he is not on the first time diagnosed, then we should start on the once a day dose of the PPI for 4 to 8 weeks and to look for the response. And also, we should look for in the primary endoscopy that whether there is any hiatus hernia is there or not, and rates and all that.
No, they have mentioned that if there is a gastroesophageal valve laxity and no hiatus hernia, then how do you manage these people? So do you send them for surgery or GERD therapy or what?
No. If the patient is means responding well on the PPI, or even after optimizing PPI, we can monitor them on the PPI and along with the lifestyle and dietary modifications.
Okay.
And if there are the persistent symptoms or patient is PPI dependent, even after optimizing the PPI and all the measures, then only we should think for the surgical or the endoscopic measure.
Okay. Rajesh sir, are you there, sir?
Yes, very much.
So I had a question. Many a times, what happened that if the patient had not taken adequate PPI, like they had taken it for 2 weeks, and the pH metry and manometry was done. Now, on manometry, there was ineffective peristalsis and very low pressure of diaphragmatic ring, so much so that hypertonia was not visible. Once the patient took adequate 6 to 8 weeks of PPI, then manometry was repeated. At the time, at that time, the ineffective motility was there, but hypertonia was seen. Now, what is the significance of this kind of problems, and how do we approach these patients?
Yeah, so it is exactly like how you see when you do endoscopy. If the patient has a sliding hiatus hernia, it may not always be seen. It's like when we are doing endoscopy, you see the hernia while going in because the patient may be retching, especially if you're doing an unsedated. And when you're coming out after looking at the duodenum, the hernia is not visible and you can see only a lax LES. So that's exactly the same way in a manometry. At times, a manometry is not the ideal method to diagnose your hiatus hernia. It is a supportive testing. Your diagnosis of hiatus hernia should be on your endoscopy. Yeah, so I would look at it as this patient has a hypotensive LES, and even after therapy, they still continue to have an hypotensive LES with ineffective motility.
Okay. Thank you, sir. Thank you for your inputs. If we have any other questions, otherwise we can move to the quiz.
I have one question. Sir, do you do routinely multiple rapid swallow and free water challenge to your patients? And if suppose patient have ineffective motility and with provocative test, if patient do not have an improvement in DCI, then what you suggest to your surgeon?
Yeah, so if the rapid swallows, so I don't do rapid swallows if the patient had normal motility. So only in a patient who has ineffective motility, since I do the test myself and not the technician, but before the test is over, I know whether this patient has normal motility or not. So if they have ineffective motility and the rapid swallow shows a poor peristaltic reserve, I tell our surgeons to do a 270 degrees. That's what I would tell them to do, a two-pay and not a complete.
Okay. Thank you, sir.
Thank you. I thank all the panelists for the participation. Now we have a quiz for our delegates. So even panelists, if they want, they can participate in it. We have to log into a website known as kahoot.it, KAHOOT.IT. Shakti, can you start the quiz? So this is our game pin. We have to insert this game pin on this web page. So your game pin is 5658223. So you insert this game pin. We already have almost 10-12 people participating in the quiz. So among the attendees, Dr. Dhruv, who is already there, he was the last time winner of the quiz. So if we have 16 people now, we'll wait for 15 seconds more and then we'll start. Shakti, you can start now. Yeah, so we'll start with the first question. Move to the first question, please. So your question is, all of the following are complications of GERD except. You on your screen, you have various colors. So you, whatever you feel is the right answer, you have to click it. Peptic stricture, Barrett's esophagus. So squamous cell carcinoma is the right answer. We'll move to the next one. Next one. All are the known side effects of PPI. Vitamin D deficiency, vitamin A deficiency, folic acid deficiency, and vitamin E deficiency.
Actually, it is which of the following is the side effect of PPI? We can read like that. Yeah.
Next. So Ravi is leading right now. Now Dhaval is leading. Next. All are treatments of GERD except RYGB, that is Roux-en-Y gastric bypass. ARMA is endoscopic treatment of mucosal ablation, Heller or Dodd fundoplication, and sleeve gastrectomy. Next. Which of the following is mandatory before hiatal hernia surgery? Barium swallow, esophageal biopsy, CECT abdomen, and esophageal manometry. You can move to the next question, please. Which of the following are GERD mimicking disorders? Which of the following are GERD mimicking disorders except eclasia cardia, eosinophilic esophagitis, esophageal hypersensitivity, esophageal leiomyoma? So basically we are discussing the differential diagnosis of GERD. Next, please. So all are PPI responsive disorders except functional heartburn, esophageal hypersensitivity, eosinophilic esophagitis, and erosive esophagitis. Thank you. Next, please. Esophageal pH metry is indicated in all of the following except before hiatus hernia surgery, PPI non-responsive GERD, Barrett's esophagus, extraesophageal manifestation of GERD. Barrett's esophagus is the right answer. Next. All are definite indicators of GERD. Acid exposure time more than 6%, Barrett's esophagus, LA grade B esophagitis, and peptic stricture. We have to find out the odd one out. So LA grade B is not very specific. Next. Response to PPI is least in following condition. Functional heartburn, NERD, esophageal hypersensitivity, and esophageal eosinophilic esophagitis. So functional heartburn is the answer. Next. All are treatment of Barrett's esophagus. Yes. All are treatment of Barrett's esophagus except ESD, CAP, EMR, RFA, surgery. A surgery is not the first line treatment. So next, please. So Dr. Mukesh is second and winner is Dr. Dhaval. So congratulations to the winners, and it was an interesting quiz. So this is a very important, very lovely live platform. We thought that it would be interesting to involve everybody into this type of quiz. So thank you everyone for participating. Thank you, sir. Thank you all panelists for the interesting discussion and enlightening with your thoughts. Thank you, sir.
Thank you, everyone.
So much.
Bye-bye.
Bye. Good night.
Good night.
Good night. Thank you, sir.
Recording stopped.